Shall we get going?
Yeah, let's do it. Let's do
All
it.
right. Hello, everyone. I'm Ross.
Hey, I'm Eduardo.
Yeah, we're happy to start the first monthly hemodynamic congestion and perfusion rounds. Um, really, kind of the idea for this came out of the fact that Eduardo and I actually meet every week or to talk about venous congestion as part of a study in VExUS, and we review all the different images and all the different clips for the patients that were recruited in the past little while, and we talk about all right, what could be going on here, and we thought and hope that other people might find those discussions that we were having interesting. And then it kind of said, well, let's not just talk about venous congestion. Let's actually bring in eventually guests that are experts in these different fields that we can have these kind of more casual conversations. So this isn't meant to be a really like heavy kind of slide based presentation here. It's going to be a bit more organic, a bit more of a discussion. We're not entirely sure where we're going to go, but either way, we're kind of looking forward to it. Yeah, Eduardo and I, we've known each other for few years now, right?
Yeah, I think the first time I met you in live was in some Montreal meeting hosted by Philippe Rolla. We actually wrestled. Do you remember that?
Oh yeah, yeah. Oh, I totally forgot. Yeah, so we
We
did
did
a
some
MMA.
Brazilian jiu-jitsu, and
Yeah, we did
yeah,
Brazilian Jiu-Jitsu as part of the conference. That was fun.
yeah, that was the
Yeah,
first time
you're a
I met you. I didn't
beast.
know who you were, but I was assigned to fight with you, and I said, "Oh my, this guy's tough."
Yeah, yeah. Likewise, likewise. I was pretty sore and like bruised by the end of it. That was fun. We also have the distinct honor and privilege of having been robbed together at an Airbnb in Montreal. That was great.
That's true.
Yeah, I guess we could briefly tell that story while people are trickling in. So Eduardo and I, we were staying in an Airbnb in Montreal, and we come back in the evening, and there's two people in our living room,
Yeah.
and they look very suspicious, and they have a couple of our bottles of wines, kind of in one of their tucked in their bag, and so I was like, oh, like, can I help you? And they're like, oh, well, we're just waiting for somebody. Like, oh, we can wait outside and all that. I was like, oh, like, well, let me show you the door out as I'm kind of kicking out these robbers and trying to avoid a confrontation. So Eduardo goes to his room and gets ready for dinner, comes back, and he's like, oh, like, are those two people part of the conference? Are they faculty? I was like, no, 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 Eduardo, they were just robbing us. And like you Canadians are so polite that I didn't even realize we were being robbed.
Yeah, I just want everybody to know, like Canadians treat their robbers like completely in a very polite way, very different than any of us would do this in Latin America. I was completely unaware that these were intruders.
What can I say? We take care of our own, I guess. All
Yeah,
right. So thanks again for joining us. Again, if you have questions, pop them in the chat here. Just put your email address, and that way, if we don't get to them live, we'll shoot you an email with our kind of thoughts afterwards and any resources we have. And you can always reach out on Twitter for and shoot us a DM or whatever. We're happy to engage and discuss this more. You know what? Before we start, though, actually, I'm really excited to announce that we have a sponsor for HCP Rounds. So I've had the chance to get to know the co-founders of FlowSonics for the past about 8 years now, Joe and John, and what they have produced is actually quite amazing. It's a wearable wireless Doppler ultrasound that interrogates the carotid and the jugular and can answer questions about fluid responsiveness, fluid tolerance, venous congestion, all the things that we're discussing with HCP Rounds. And we weren't actually thinking about having a sponsor because when we launched this, but after a few discussions, it really just made sense to have them come because this is really their mission is to improve precision fluid management and to help the medical community get access to some of these concepts in a simpler way. Anyone can put the flow patch on. It could be a nurse, it could be a physician, it could be really anyone, as opposed to having expert performing VExUS and more complicated assessments. And just beyond that, the team at FlowSonics, they're great people. They're really passionate and motivated to help with fluid resuscitation, precision fluid management. And so, thanks again for sponsoring HCP rounds, and we look forward to hearing more and to seeing more about what you guys are doing with all the research in the field and how you're contributing. So, thank you guys. So I guess maybe I'll start off a little bit. We probably have a pretty broad audience here today. Some people who are experts in venous congestion and want to dive really deep into advanced congestion and tricuspid regurg and cirrhosis, but other people who this might be the first time hearing about venous congestion. So we'll start for the first few minutes here with a bit of an intro, and then we'll start ramping it up as we dive a little bit deeper. And the first thing I wanted to introduce was the concept of renal perfusion pressure. Every organ has a perfusion pressure. And for those of you in the ICU, we're really familiar with the idea of, for example, intracranial pressure and cerebral perfusion pressure, MAP minus ICP. but every organ actually has a perfusion pressure, the inflow pressure, but we also consider the outflow pressure. And if in the ICU your MAP dropped from 70 down to 50 for your patient, you would quickly put them on vasopressors and identify that oh gosh, we need to treat this. But when that CVP increases from say 5 to 15, there's not the same degree of kind of alarms that often goes off. But this can similarly affect the renal perfusion pressure. And this is why elevated CVP is associated with acute kidney injury. These are patients with septic shock, particularly when you get into that 12 or 14 range. When you look at broader populations of critically ill patients, you can also see that or elevated CVP is associated with acute kidney injury, perhaps even more so in patients with lower blood pressures. Again, maybe suggesting that renal perfusion pressure is really just so important. But there's a problem here, and the reason why we're going to be talking about Doppler today is that the sensitivity and specificity for CVP to predict acute kidney injury is actually very poor. And so for that patient in front of you, just because they have a high CVP, doesn't necessarily mean that they're going to get an acute kidney injury. So we need to refine this further. And there's a couple of reasons why the CVP fails. Eduardo is going to talk about this a little bit later, but one is that the pressure at the right atrium is not necessarily the pressure or congestion being felt at the kidneys. You have intrathoracic pressures, cardiac pressures, pericardial pressures, intra-abdominal pressures, all that interplay with each other and might change that. And similarly, some patients actually require a higher CVP to maintain forward flow. If you have a patient with severe pulmonary hypertension, CVP of 8 for them might be too low for them to push blood forward. And by dropping their CVP, you could cause acute kidney injury. So this has led researchers to be interested in organ level assessment of congestion. And one of the tools to do that is Doppler ultrasound. And so a lot of this was out of the work from Dr. Deneau and his group in Montreal. And they found that in cardiac surgical patients, venous congestion, as measured by, in this situation, single vein pulsatility, was associated with acute kidney injury following cardiac surgery. Now, there's been numerous different studies in different populations. I'll just highlight a couple here. This is another cardiac surgical population. On the left, you can see that patients with high degrees of portal vein pulsatility have an increased hazard of developing acute kidney injury. And similarly, patients with abnormal intrarenal venous flow, which we're going to talk about a fair bit here, have increased hazard for acute kidney injury. So there's definitely an association. Whether or not this is agnostic, causal, those are still questions that we're answering in the literature, but there's certainly a strong association. So maybe I'll hand this over to you, Eduardo. Why don't you just walk us through a little bit of what are these different waveforms? How do you interpret them? And what actually causes abnormal waveforms like we see here with the VExUS score, which is a composite score of a bunch of these different waveforms?
Yeah, well, first off, I love looking at these waveforms. There's something satisfying about looking at the hemodynamics happening in real time. And I just want everybody to know first that this is by no means is something new. I mean, this has become really popular this last couple of years. But venous Doppler has been around for decades, especially hepatic vein Doppler. Like everybody who's known or done echocardiography before is familiar with interpreting the hepatic vein Doppler waveforms. And that's probably the most complicated one because there's different components due to its vicinity with the right atrium. Anything that happens in the right atrium, any change in pressure that happens in the right atrium will create a different velocity in blood. And it might actually inverse or reverse the blood flow, which usually venous return is from the liver to the heart, and might actually end up reversing it from some parts of the cardiac cycle. So if you look at the first square there with a normal hepatic vein Doppler, I'm sure you can point it out, Ross. You'll see that there's a small wave above the baseline, and that's actually blood flow going from the heart back to the liver. And that's your A wave, and it's happening at the same time as your atrial contraction, right? And then as your right atrium relaxes, this will suck blood back from the liver to the heart. And this will cause your systolic wave or your S wave. And, it's called systolic because it coincides with the right ventricular systole, but really most of the blood going from the liver to the heart in this part of the cardiac cycle is because of right atrial relaxation. And then finally, your right ventricle relaxes, and it will give you a diastolic wave because of the right ventricle, again, sucks blood from the liver to the heart. And then that'll give you your D wave. And that's your normal hepatic vein morphology with a reversed small A wave a large S wave and a smaller D wave, which are both antegrade. And this can get very complicated very soon when you start having some right ventricular abnormalities, either increased right ventricular stiffness, or altered valvular function, or pericardial diseases. So you can have all sorts of abnormalities of the hepatic vein Doppler. And this is really complicated, really, to evaluate what we call a systemic venous congestion. So, personally, I don't really use the hepatic vein to assess organ congestion, but I really use it to make some diagnosis. So, for example, when you have an increased RV stiffness, this is your mild abnormality. You'll see a decrease in the amplitude of the S wave compared to the D wave, and this is usually seen in a low compliant RV. This can also be seen in mild or moderate tricuspid regurgitation. And then if you go to your severe abnormality, that's a reverse S wave, which means all the flow during the systole is going back to the liver. And of course, you can picture this in your mind as being the result of severe tricuspid regurgitation, because all flow in systole, the RV is ejecting it back into the liver. And then that's a waveform that does inform an organ congestion, because all this blood flow going back to the organs is actually responsible for creating organ edema. And then that's a severe abnormality to consider. Now, after I talk about hepatic vein, because that's a very difficult vein to interpret, my favorite actually part of the exam is the portal and the intrarenal venous Doppler, because that's actually looking at the organ hemodynamics, that the target organs, which we are trying to assess whether they're congested or not, whether there's congestive organ injury. And I think the evidence will show that these are the real game changers. When you do portal vein Doppler and renal venous Doppler, you're actually assessing whether blood flow is going back from the right atrium to the small capillaries of the liver and the kidneys, and actually causing an altered venous blood flow. But that's telling you that a large amount of blood is returning from the right atrium all the way to the small capillary beds of these organs. And that has to be pathologic, right? And as you can see, the normal portal vein Doppler is a continuous waveform. So flow is going from the gut and from the spleen to the portal system, to the portal vein, without interruptions. It's completely continuous or very mildly pulsatile. And as you become more congested, and this is not only a high CVP, but also a high right atrial volume, reaching all the way to the plateau part of the compliance curve. So once your right atrium cannot accommodate any more volume, and your peripheral veins cannot accommodate any more volume, any change in right atrial pressure will create a large flow that's transmitted from the right atrium to the portal vein. And that's very pathologic. And it will interrupt the continuous normal flow that we see. And this will manifest as portal vein pulsatility. As you can see in your mild abnormality, your portal vein starts becoming a little bit pulsatile, more than 30%. What we mean by that is that the velocity, the highest velocity and the lower velocity of these trace are the difference between them is greater than 30%. And when there's more degrees of congestion, and then again your compliance, or your right atrium compliance, is completely saturated, then a lot of blood flow is going to go back to the portal vein and cause very high pulsatility, and that will be usually associated with a pulsatility fraction greater than 50%. We in our group, as we deal with more right-sided heart failure patients, we actually define this as greater than 70%, but the literature, you'll find it as 50%. And now for the intrarenal venous Doppler, is the same principle. Instead of looking at the portal vein, you're looking at the small parenchymal vessels of the kidneys, and normal blood flow in these small vessels that are very far away from the right heart is continuous and non-interrupted. Here in the kidneys, it gets a little bit complicated because you cannot isolate only a vein. You will usually get both an arterial tracing and a venous tracing. So above the baseline, you'll see the arterial tracing, and that's a very characteristic systolic and diastolic blood flow. But below the baseline, that's where I want you to pay attention. You see the venous waveform as signaled right now by Ross. This is what he's signaling right now. That's a venous waveform, and it's a continuous flow, non-interrupted. And as congestion progresses and your right atrium compliance saturates, and your peripheral venous compliance saturates, then you start seeing interruptions. So your mild abnormality is characterized by 2 interruptions per cardiac cycle. So you'll see 1 interruption before the systolic wave and 1 interruption before the diastolic waveform. So there's 2 waves per each cardiac cycle, and that's what we call this pattern of flow, a biphasic pattern. And then your last square, which is the severe intrarenal Doppler abnormality, it really shows a complete interruption of blood flow during the whole of systole, and only a small amount of venous return happening during diastole. This is usually seen also in severe tricuspid regurgitation, because all blood flow during systole is actually going back to the kidneys instead of going forward. But you can also see this, in a very restrictive feeling pattern of the RV, so a very restrictive RV with increased volume. And you can also see this in patients with atrial fibrillation and severe congestion, which will cause all the systolic blood flow to go back.
Wonderful. Thank you for that, Eduardo. I'm just going to double tap on 2 things that you said that I think are just so important. So the first is that, and this takes, if you're not thinking about kind of the portal venous anatomy all the time, I just wanted to double tap on this. So to get portal vein pulsatility or even portal vein reversal, you need blood to go from the right atrium to the IVC to the hepatic vein, cross the hepatic sinusoids into the portal system. So that's when Eduardo says that there's a capillary level. You have actually reversed blood flow across the capillaries in the hepatic sinusoids, which is why it's more significant than the hepatic vein, which is more reflective of right atrial pressure.
That's absolutely
This,
true. I mean, the portal vein is sit in between the hepatic sinusoid and the right atrium. So for flow to go from the right atrium all the way to the portal vein, it has to go through the liver sinusoid. So it's really reflective of what's going on at the capillary bedside.
Perfect. And then the second thing is that when we're doing the intrarenal venous Doppler, we're not actually measuring the renal vein. We're measuring these small little kind of venules in the renal cortex. And when you pulse them, that's much more reflective of capillary. If you're doing a portal vein, or sorry, a renal vein Doppler, and you place it on the hilum, you actually get what looks more like a hepatic vein tracing because it's similar vessel coming off the IVC. But when you go into the actual renal cortex, which is what is advocated for, you get this non-pulsatile continuous pattern, which is what we're trying to measure. All right,
Yeah.
but so why do we actually need VExUS, and why can't we just use CVP? Because I said earlier that CVP was associated with acute kidney injury. The first thing is that the predictive accuracy of VExUS predict acute kidney injury is greater than CVP. So if you look at this leaf plot on the left, if you take a pretest probability, you say that the patient has a positive test and positive VExUS, their pretest probability goes from, say, 34% to 78% that they're going to develop acute kidney injury. But the same thing for an elevated CVP only goes from 34 to 50%. And there's empiric evidence from multiple studies, Eduardo is going to share a little bit as well, that CVP is just not as good at predicting acute kidney injury because of all these factors. So going to the actual organ that we care about is what's most important. But this actually does raise the question, and Eduardo has already alluded to this, like what actually causes venous congestion? Is it just volume overload? Are there other contributors? And how do we actually then identify the cause of congestion and potential treatment? And so I just want to emphasize that venous congestion is not the same as volume overload. There's sometimes a simplistic view in our minds that venous congestion is, well, it's just high right atrial pressure, it's transmitted to the IJ and the IVC, and then that goes to the kidney, and that causes congestion. In some cases, that's true, but there may be more nuance and more complexity to this. And so it's not just the volume status of the patient that matters, there's more. So the first is that there's the cardiac function. This could be RV systolic function, diastolic function, elevated PA pressures, pericardial disease like pericardial effusions. Even if there isn't tamponade, large pericardial effusions actually can cause significant venous congestion and organ injury. And then tricuspid regurg, which we'll talk about a bit more later. Positive pressure ventilation, PEEP, and pleural effusions are really significant. And so, for example, if you have a patient who has and you increase their PEEP from 5 to 10 to 15 to 20, as you start over distending their lungs, you can actually see changes in the renal venous stasis index and the intrarenal venous Doppler flows that reflect that over distension in the thoracic cavity being transmitted down into the abdominal organs. And also pleural effusions. We had a case of a large pleural effusion that we put a chest tube in before the drainage. There was severe renal congestion. After the drainage, almost immediately normalization of the renal congestion pattern. And this is because we sometimes think about the thoracic cavity and the intra-abdominal cavity as separate, but really they're just separated by this tiny little diaphragm. The pressure in one cavity certainly influences the pressure in the other. IV fluids and volume status can definitely contribute to venous congestion, as can the intra-abdominal pressure, renal edema, things like IVC stenoses. We had a case of a patient with a IVC stenosis from a thrombus who had severe renal congestion and renal failure. As soon as that thrombus was taken away in the operating room, the patient immediately recovered their renal function and recovered their renal congestion. Maybe I'll hand this over to you to ask you a question, Eduardo. So, how do you think about causes of venous congestion, and maybe specifically, are there any types of venous congestion that are not amenable to diuresis? Because often there's this kind of like VExUS Lasix reflex that is developed where people see congestion, they want to give Lasix. When does that fail us, for example?
Yeah, well, it's going to fail every time if you think of VExUS or venous Doppler as a way to assess fluid status. And it's really not what this tool is made for. This tool is a tool to assess how your right atrial pressure is being transmitted, not the pressure, but the actual flow of the right atrium is being transmitted back into the abdominal or peripheral organs. This might even be the brain, and how this might predict or is actually predicting or congestive organ injury better than any other measure that we can make in our patients, even invasive measurements. So VExUS or venous Doppler is not a volume status assessment tool, but it's an organ congestion assessment tool. So it will only assess congestion in patients that have congestion, and congestion is only seen in patients with right heart failure, right? And so if you don't have heart failure, you'll see no congestion. You can have a young patient with a completely normal heart, pancreatitis, that's 20, 30 liters positive fluid balance. If the heart is normal, you'll see zero congestion. The IVC will still be small. The venous Doppler will be normal, but the patient will have a lot of effusions and edema, third spacing because of the septic process. Now, on the other hand, if you have heart failure, right heart failure specifically, and you volume overload this patient, then congestion will get worse. But the actual tool, the actual assessment of congestion at the bedside cannot tell you whether this is from volume or from just a severe alteration in right ventricular dynamics. So you have to say, I am assessing the consequences, the organ consequences of right heart failure, and is right heart failure leading to congestive hepatopathy, congestive nephropathy, or other organs being congested. And so that being said, the most common cause of congestion is heart failure, left heart failure, either with a preserved ejection fraction or a reduced ejection fraction, and that will cause secondary right heart failure and congestion. So that's very frequent because a lot of our patients have heart failure with preserved ejection fraction. And I would say if your problem is a left-sided problem, then I'm willing to bet that 95 to 99% of the time, congestion will improve with diuretics. And this is what we see all the time. Like most of the times, you see that congestion will improve with volume removal or diuretics because it's coming from a left-sided heart problem. And I will tell you, in our experience, even in patients with primary right heart failure, and that's your pulmonary arterial hypertension or your precapillary pulmonary hypertension, where there's severe congestion, and I'm saying a portal vein pulsatility greater than 70, greater than 100%, this is almost always amenable to treatment with diuretics. Now, of course, there's some conditions where you cannot remove congestion with diuretics, and that, of course, is your cardiac tamponade, your a massive pulmonary embolism. We just had a case, very, very interesting case of a giant atrial sarcoma. And there's this giant ball in the right atrium causing venous congestion. The pressure in the right atrium needed to be so high, and in order for the this sarcoma not to obstruct blood flow, that when we gave a little bit of diuretics just to remove organ congestion, trying to improve liver or kidney function, this tumor mass will just impact in the tricuspid annulus, and in blood flow, actually cardiac output will drop to zero, and the patient will go into cardiogenic shock, and we will need to resuscitate with fluids. And of course, the treatment of this patient was not diuretics. We wanted to decongest the liver, we wanted to decongest the kidneys. This cannot be achieved with diuretics. It had to be achieved with cardiac surgery. And
Mm.
another fascinating disease that also can lead to organ congestion regardless of volume status is a primary tricuspid valve problems. As you know, we are studying a lot of patients with tricuspid
Wait,
regurgitation
and
in our, yeah.
so Eduardo, you actually have a tricuspid regurg clinic that you manage, which I mean, when I look at an echo report and I see tricuspid regurg, I kind of like gloss over it. I'm like, all right, what's going on with the aortic valve, the mitral valve, like the left sided, they're sexier somehow. But you have an entire dedicated and research arm, dedicated clinical and research arm focused on tricuspid regurg. I'm very curious to pick your brain on that. So just tell me a bit more about that. How does tricuspid regurg cause congestion, and how do our tools, for example, VExUS, differ when we're assessing somebody with severe TR compared with somebody with just a left-sided heart failure, as you said? And yeah, I'm really curious to dive into that a little bit more here.
Yeah, sure. Well, this is actually a fun story because I'm a nephrologist and I'm having a tricuspid regurgitation clinic. I'm not a cardiologist or cardiac surgeon, but I have a lot of consultations. So I used to have a lot of consultations on patients with severe congestion, like sometimes it's spectacularly severe congestions. And we started learning that most of these are actually caused by a primary valvular tricuspid issue. And that's where we started getting involved in decongestion. That is what we nephrologists like to do. We take volume out of the patient. So anytime I would get a chance, I'll try to get volume out of this patient and monitor how congestion is improving. And this is how we began actually prospectively studying how patients with severe tricuspid regurgitation get decongested, and what are the venous Doppler changes that we see with decongestion. I'd like to share this maybe with you and the audience. I'm not sure if you can see my screen now. I think you can.
Yeah, yeah, that's perfect there.
Yeah,
Yeah.
great. So this is our problem of interest. A patient with a flailed tricuspid valve, either this be congenital or acquired, but a primary tricuspid valve issue that, all the time, every cardiac cycle with every systole, there's going to be a torrential return of blood from the right atrium to the organs. And this will, of course, if severe enough, even if not volume overloaded, it will cause an interruption in your normal Doppler waveform. So as you can see here, I'm actually going to choose a pen so I can draw it better. You'll see this intrarenal venous Doppler where there's really no blood flow going on for all of systole, and you only get this small venous return during diastole. And the reason for that is that during systole, there's a large amount of blood that's returning to the kidneys because of the flail tricuspid valve, not necessarily because of volume overload.
Yeah, that's interesting. So just to clarify, so below the baseline, for those that might not be as familiar with intrarenal venous Dopplers, so above the baseline is arterial. Here, let me try to draw it here. And just correct me. So we have our arterial tracing kind of above the baseline here, and then we have a venous tracing below the baseline, but we don't see the venous tracing throughout the entire cardiac cycle. There's this big period here from here to here that's disconnected, and the reason why, or discontinuous flow. And the reason why is not that it just disappears, but it's actually retrograde. And unlike the hepatic vein, where we visualize the retrograde flow because we don't have an arterial tracing, there is still retrograde flow here. It's just hidden behind the arterial tracing. So if I were to, and we're going to have to maybe make a little bit of pretend here just to see, but for example, I could draw a venous tracing. You can almost imagine that this is sort of the shape of the venous tracing that's lying underneath it. So this is our reversal wave, like an AS reversal wave here, and we're just not visualizing it. Is that a fair
Yeah,
summary there?
actually, I love that you drew that because I was actually thinking you can might maybe see that Venus bump right here. Like I will draw it again, and this is exactly where the Venus waveform should be behaving. Like in systole, it's going back into the kidneys, and this is actually causing renal congestion. I mean, this is
Mm.
causing renal injury, hepatic injury. You will see that there's large studies now done in patients with tricuspid regurgitation, and some of the main determinants of outcomes is actually liver and kidney function. And
Mm.
sometimes there's no way to decongest these organs because this is not a volume related problem in some of these patients. So these patients will be already euvolemic or even hypovolemic and still have a torrential jet of tricuspid regurgitation going back to the kidneys, going back to the liver. This is assessed by intrarenal venous Doppler, but this is no way to treat this with extra amount of diuretics because CVP is already low. So if you keep removing volume, then you will decrease preload, and then of course you will have a forward flow problem. But still, even if this is not mediated by volume overload, this is still causing organ congestion, and other treatments can be put in place, such as tricuspid valve replacement or a triclip. And
Okay,
so,
can I just double tap on that point there? Because I think that's such an excellent point. So just because we can't treat the congestion and normalize the intrarenal venous Doppler effectively in tricuspid regurg because we can only diurese them so far, doesn't mean that the congestion is not pathogenic. It's just not a medical problem. There needs to be a surgical or a mechanical fix to this problem. And if, for example, and I know we've seen a couple cases where you have patients with severe renal congestion, they undergo a triclip or a tricuspid valve repair, and then immediately afterwards their renal congestion has almost resolved, and their renal function, their creatinine, which has been hanging out about say 150 for like months and months and months and months, suddenly their creatinine comes down to a new baseline because they were baseline had congestive nephropathy chronically because we could
yes.
never decongest them. Do you see that as well in your patients?
Yeah, this is absolutely true. And what I want to say is the Doppler is not lying. The kidneys are
Yeah.
truly congested. They're receiving a large amount of blood flow every cardiac cycle that's coming back into the small vessels of the kidney. But this is not. Sometimes you cannot treat this with diuretics, and of course a tricuspid valve intervention can definitely improve organ congestion. That said, does this mean that then we cannot use venous Doppler to monitor volume status in patients with severe tricuspid regurgitation? This is really the question that we
Mm.
had. Does that mean we have to abandon this? Because of course, if the patient has such a severe tricuspid regurgitation, we can never improve venous Doppler. So, is this really a monitoring tool, or is this really more of a diagnostic tool for a proceduralist before doing a tricuspid valve repair? And that's how we started our research. I want to show more of our research here. This was our index case. If you actually look at it, this is a patient that came in to the emergency department with a primary valvular severe tricuspid regurgitation and very noticeably volume overloaded. So a lot of peripheral edema, pleural effusions. It was clear that the patient was volume overloaded. And if you actually look at the congestion, ultrasound congestion assessment, you'll see a very plethoric and dilated inferior vena cava. Of course, a very interrupted intrarenal flow with a interruption in systole, as you would expect in severe TR. And look at this. This is the portal vein pulsatility fraction. This is actually the largest portal vein pulsatility fraction that I have seen. This is a 240% pulsatile portal vein. That means the flow going back to the portal and the intestines and the spleen has a greater velocity than the flow going to the heart. So this is such a severe, staggering congestion. And what we did was aggressively diurese this patient with the IV diuretics. I think we took 15 liters off of this patient and monitor every 48 hours. And you'll see what's very interesting to us is the portal vein normalizes progressively with volume removal. And it does track volume removal in these patients, even in primary tricuspid regurgitation. And of
Mm.
course, you will see that the inferior vena cava has no changes and the intrarenal venous Doppler has no changes. So, of course, then persistently severe tricuspid regurgitation cannot be monitored with intrarenal venous Doppler or with the inferior vena cava. But for some reason, I still don't understand. Maybe the portal vein is protected from this tricuspid regurgitation, yet from the sinusoidal resistance. But for some reason, the portal vein improves with volume removal. And this is not an isolated case. I mean, we've now have a large prospective series accepted for publication in this very good journal, which is the European Heart Journal Acute Cardiovascular Care, and where we prospectively decongested patients with severe tricuspid regurgitation and severe congestion. And as you can see, even in these patients with such severe TR, we can actually improve, in most of them, we can improve the portal vein to less than 50%. So this is actually a good tool for monitoring volume overload in patients with tricuspid regurgitation, because all of them come with a very high portal vein pulsatility fraction, and with diuretics or volume removal, portal vein normalizes.
In
Yeah.
severe TR, would you say that less than 50% should be a target if you were going to use portal vein pulsatility as a target?
Actually, that was one of the key points of the paper. The paper actually asked us to write some key points, and I think some of the takeaway points from our study is that even in persistent severe TR, we can get the portal vein below 50% in more than
Mm,
80 to 90% of our cohort. So yes, I think it should be a target. And now I would say sometimes when you are aggressively decongesting these patients, you'll realize that most or some of the severe TR was coming from tricuspid annulus dilation, and it'll snatch back into position, and the tricuspid valve will now be closing with a better
mm,
performance, and the TR will decrease. Now, if TR goes away, then your goal of portal vein pulsatility should be completely normalized, less than 30%.
mm,
But if TR is persistently severe, then at least 50% is achievable. And you can see
mm,
we saw this phenomenon with the decongestion as measured in the renal Doppler signal. You see, most of our patients with severe TR, when we decongest them all the way to, we cannot longer take any more volume. Like we're giving a lot of diuretics. These patients are already hypovolemic. In fact, I was telling you about this the other day. We are still pushing diuretics when the portal vein is normal, and the patient can no longer tolerate volume removal. We'll see some signs of hypovolemia, and that's pre-renal azotemia, some orthostatic hypotension, and some curiously, we started seeing a lot of cramps. So
mm.
patients will start complaining of cramps in the legs, cramps in the arms, cramps in the back, and that's funny because it's not very well reported that when you aggressively titrate diuretics in a patient with severe TR, you'll get these cramps, and that's something we realized. Once the patient starts cramping, we already know that the portal vein is going to be flat.
And is that just electrolytes? Like you're just their potassium's 2.1 there, or is this independent of electrolyte abnormalities?
Yeah, no, that's completely independent. We are
Oh,
replacing electrolytes aggressively. We have laboratory data in all these patients, and they had no low magnesium or low potassium. That was not the
mm,
problem. The problem, I think, was true that we reached the euvolemia, and we were pushing a little bit into the hypovolemia realm. And this is not something surprising for nephrologists. We take fluid with ultrafiltration all the time, and some of the side effects of taking fluid is cramps. When you get hypovolemia and low cardiac output, for some reason, one manifestation is cramping, and we know that's a point to stop or at least lower the ultrafiltration rate. And we started seeing this happening when we were pushing diuretics in patients with severe TR who had a completely normal portal vein, which is interesting. Now,
interesting.
for some patients, when we aggressively decongested, aggressively took volume out, the tricuspid regurgitation improved. And that's what I was telling you about. The tricuspid annulus just snatches back into position. The tricuspid valve is now closing. Perfect. And those who have improved tricuspid regurgitation, now we can see a complete normalization of your intrarenal venous Doppler.
Mm,
But if you have persistently severe TR, your renal Doppler will never improve. And this is what we show in this paper. This is a cohort of patients who had severe or torrential TR before removing volume and remained with severe or torrential TR after removing volume. And as you can see, the intrarenal Doppler stays the same, so we cannot really use it to monitor volume removal. And the vena cava, of course, stays the same because this torrential yet will, dilate your vena cava and don't allow it to collapse. But this is what's significant. I think this is beautiful. We can actually monitor volume removal in these very severely congested patients by measuring the portal vein sequentially. And we see that after decongestion, most of these patients, even with persistently severe TR, can have a normalization of the portal vein.
mm.
So yeah, I agree. Maybe a good a target for decongestion in this population of patients is at least go below 50. That's
Yeah.
reasonable. It's achievable, and it's associated with zero side effects. If you try to completely normalize it, the vena cava or the renal venous stasis index or the intrarenal venous Doppler, if you try to normalize that, you'll get cramps, and that's the least of your problems. You can get hypotension, you can get a pre-renal azotemia. So that's our data on tricuspid regurgitation, and I find it very interesting. And this is once you start studying tricuspid regurgitation, you start wondering whether venous congestion can affect other organ sites. We've usually focused on the kidneys a lot in our venous Doppler or venous congestion research, but there are other organs that can get congested, and I think those are interesting research questions.
Yeah, do you want to dive into that a little bit then? So I guess in my mind, when I think about congestive organ injury, I always think about the kidney. But then we have some literature from Dr. Deneau's group um, that venous congestion is associated with delirium in post-cardiac surgical patients with cerebral desaturations, and and even actually there's some intraoperative data with kind of brain oximetry that when you put patients head down and you increase their venous pressure and venous congestion, you actually see cerebral desaturations, which is fascinating. We're actually looking at this here in London, where we're studying patients with septic shock and looking at the association between venous congestion and delirium and long-term cognitive outcomes. So definitely congestive kind of brain edema is a consideration. There's cardiointestinal syndrome as well, which we don't talk about a ton, but in patients with heart failure, the congestion of the bowels leads to inflammation, release of various kind of biomarkers that may actually cause worsening cardiac dysfunction, and this could be involved in some of the pathogenesis of acute heart failure. We have
Uh,
congestive, like interstitial edema, which we know that when the interstitium of our legs, extremities get edematous, we result in kind of muscle dysfunction. We can't mobilize. There's complications associated with that. Pulmonary edema, congestive pulmonary disease, we're all familiar with. And then there's congestive hepatopathy, and I know that you guys have recently done some pretty cool research into congestive hepatopathy as a second kind of either like mechanistically how congestion causes congestive hepatopathy, but also potentially following congestive hepatopathy as a marker of decongestion. So I'm really, yeah, why don't you share some of your experiences with that? That's a great idea.
Yeah, sure. First, before I talk about congestive hepatopathy, I want to show like what was the main idea behind studying venous Doppler associated with congestive organ injury. And this is we chose to study the intrarenal Doppler because I think it has a special way to quantify congestion that's not captured by other Doppler sites such as the portal vein or the hepatic vein. The renal Doppler, if it can be made very quantitative if you
Mm,
actually take into account the amount of time that the venous flow is interrupted in each cardiac cycle. So this is the percentage of time. So for example, look at this small A wave interruption. That probably is an interruption of less than 10% of the cardiac cycle. So that's a very quantitative piece of information. You'd say 10% of the cardiac cycle venous return is interrupted by flow going back from the heart to the small veins of the kidneys. So that's a very quantitative measure. And you can have many different causes of interruption. So like I point here in this slide, and you've already drawn some of the interruptions here. But look here, this small interruption is caused by a backwards A wave, so just your right atrium contracting and interrupting the flow. This larger interruption is also caused by a large A wave. This is a patient with severe pulmonary hypertension where A waves become gigantic and wide. And so there's a larger percentage of the cardiac cycle that's interrupted by the A wave. And that's a more significant degree of congestion, even if it's the same A wave causing interruptions. So now this is probably a little bit larger than 20% of the cardiac cycle, right? And now then you can also have a retrograde A wave and a retrograde D wave causing 2 interruptions per cardiac cycle. And this is greater than 30% interruptions of your cardiac cycle. And then, of course, if you have severe TR or severe restricted pattern, filling pattern of the RV, you can have a completely interrupted flow during the whole of systole in just a small flow and diastole. And that's, more than 60 or 70% of your cardiac cycle has an interruption in intrarenal venous flow. So I like this way of quantifying congestion because it's telling me for how long of each cardiac cycle is flow going back from the right atrium to the organs. And our question is this pathogenic? Is this just a
mm,
reflection of high CVP, or is this actually causing organ congestion and organ edema? If you kind picture this in your mind, there's a capillary, and the capillary has some precapillary sphincter that's preventing your high blood pressure to be transmitted to the organ, but there's no sphincter on the venous side. And so this flow going back to the organs from the venous side, could this be causing leakage and organ edema? This is one of our questions. And we chose to study this in a model of liver disease because when we study acute kidney injury, there's a bidirectional relationship between high CVP and acute kidney injury. You can have congestion causing acute kidney injury, But you can also have acute kidney injury causing congestion because, when your kidneys are diseased, you'll retain sodium, you'll retain water. So you'll see a very good relationship, a very good association between acute kidney injury and congestion measured by Doppler because it's a bidirectional relationship. And I think the liver congestion is it's a purer scientific test of organ injury. And that's why we decided to do this. And we use this measurement of intrarenal venous Doppler because we know it's different from CBP. So this group, I love this paper. This is a paper studying renal congestion in patients with precapillary pulmonary hypertension. This was led by Dr. Adeshir Gofrani. He's an expert in pulmonary hypertension and was actually performed by a nephrologist, as a friend, Fayek Hussein Sayed. And what Fayek Hussein showed is that the correlation between right atrial pressure measured with right heart cath and the renal venous stasis index, which is just the percentage of interruptions of the cardiac cycle, is a very poor, actually an R squared of 0.31. That means you can have a high CVP in a completely non-interrupted renal flow and a high CVP in a very interrupted renal flow. And there's really no way that you can predict that by doing invasive measurements. And what I like about this paper is that Fayek Hussein showed that the most important predictor of morbidity and mortality in pulmonary hypertension was not your pulmonary artery pressure, was not your right atrial pressure, was not your cardiac index, but was actually the interruptions in renal flow. So this quantification of blood going back into the kidneys and maybe also going back into the liver and going back into the brain and leading to organ dysfunction. That's why we decided to pay attention to this renal venous stasis index, or this index that tells you for how long is the venous return interrupted. So renal venous stasis index of 0 means no interruption, of 0.2 means 20% of the cardiac cycle is interrupted, of 0.88 then means 80% of the cardiac cycle is interrupted. And by studying this, we were saying, well, what if it's not completely related to CVP, what drives this more prolonged interruptions? And that very likely has to do with peripheral venous compliance and also right atrial compliance. So at some level of CVP, there will be a higher chance of blood flow going back from the heart to the kidneys. But if your peripheral veins are compliant, they will be buffering this backflow and will not allow it to reach all the way to the capillaries of the organs. But once your peripheral veins are completely distended and cannot tolerate a single drop of fluid, of extra fluid or extra blood, then these walls are very tense, very distended, and cannot accommodate this retrograde flow. And now you will have a very high transmission of atrial backflow. And this maybe what we're measuring with intrarenal venous Doppler is not only a high CVP, but also a high blood volume in regards to its compliance curve, where it can no longer be accommodated. And now it's being transmitted back and back and back to the kidneys with every cardiac cycle. And so the hypothesis is this one. When you have a high CVP, let's suppose 14, you may have a very compliant venous system that will buffer the transmission of flow to the organs, and then you'll see very little organ in dysfunction. And maybe another patient that has the same high CVP is already saturated his peripheral veins. They can no longer accommodate any single drop of volume, and then backflow from the right atrium will be easily transmitted to the liver and the kidneys, leading to congestive organ injury. That was our hypothesis. And we wanted to test this in a very, I think, a cleaner model, which is hepatic dysfunction.
Interesting. I mean, I was following you up until I looked at this diagram here. It took me a while to figure out this was a kidney and a liver together. I just realized, I thought maybe this was a multi-lobed kidney or something. But now that I'm on the same page, this makes total sense. Why don't you take us through a bit of that data there that you have?
Yeah, apologies for the overlapped images. This is a happy kidney and a happy liver, and this is a sad liver and kidney functional unit. And so, we decided to use, this might be counterintuitive to some people, we decided to actually use the renal venous Doppler to predict hepatic congestion, because it has to be the same, right? If blood flow is going back from the kidney, from the heart to the organs, well, it's going to go to the kidney, but it's also going to go to the liver. And the renal Doppler really allows me to quantify the amount of interruptions in cardiac cycles. So this is what we did. This is a manuscript that we were finishing the writing, and it's about to be sent for publication. But look at this. We evaluated the markers of cholestasis, which is congestive hepatic injury or congestive liver injury according to the interruptions in the renal flow. So those with continuous interruptions had better markers than those with short, medium, or long interruptions. So your bilirubin goes up the more congested your kidneys are, the alkaline phosphatase goes up, the gamma glutamyl transferase goes up. And if you actually look at a composite of these laboratories, which is termed in the cardiac literature as your cardiohepatic syndrome, which really just means altered cholestasis liver function test in a patient with heart failure, these were patients with primary pulmonary hypertension and not primary liver disease, so really primary pulmonary hypertension with normal liver function, supposedly. But look, this is not normal liver function. The more congestion you get in your kidneys, the more interrupted the flows in your kidneys, the more prevalence of cardiohepatic syndrome you see. And this is what's beautiful. You actually look at all the information, either biochemical, demographic, clinical, laboratory data, echocardiographic data, and adjust in a multivariate model, the best predictor of cardiohepatic syndrome by far is abnormal intrarenal Doppler. This is better than tricuspid regurgitation, better than your usual markers of right ventricular or right heart failure. And this was not only the case for laboratory abnormalities, we also measured liver stiffness. We can measure liver stiffness using a fibroscan, which is a elastography, and this tells us how rigid your liver is. The liver becomes rigid when there's more red blood cells circulating in the liver. So the more red blood cells, and that's congestion, of course, because there's more blood in the liver, the more red blood cells, the more stiffness, and this is measured in kilopascals. And you'll see the more congested your kidneys are, the more interrupted your intrarenal venous flow, the more stiff your liver is going to be. And that's very beautiful because, again, we see that the main predictor of increased liver stiffness, this is the cutoff point that's associated with high mortality in patients with heart failure. This is not a random cutoff point. This is actually based on literature. The most important predictor of increased liver stiffness, again, better than any other biochemical laboratory demographic or clinical data, is an abnormal intrarenal Doppler, right? And then finally, here's the crown. I think this is the cherry on top. When we actually compared the predictive ability of intrarenal Doppler to that of CVP or right atrial pressure measured with right heart catheter. And as you can see, we also show there's a poor correlation between the high CVP and the renal venous stasis index or the renal Doppler. But what we have seen is that the predictive ability of congestive hepatopathy, which is your cardiohepatic syndrome, is way better with your renal Doppler than when you actually measure your CVP with an invasive catheter. So I think the main takeaway point is that we believe with this data really suggests, I cannot prove, but really suggests that this backflow going from the right atrium to the organs, as quantified by the percentage of interruptions in each cardiac cycle, that means the more interruptions, the more time the blood flow is going back, it really is actually causing, it might be pathogenic in it of itself. It's not a representation of high CVP. It's not a surrogate of a high CVP. It's a really new thing we can measure at the bedside, which is the amount and the percentage of time blood flow goes back to the organs. And then this amount of blood and this time blood is going back will inevitably lead to organ congestion, high liver stiffness, and organ dysfunction. Well, at least this is what we believe now. And of course, we're in the process of studying whether decongesting patients with cardiohepatic syndrome and high liver stiffness will result in better liver function. And we hope to have this data next year.
Wow. I mean, this is incredible. This is something that I admittedly haven't done a ton of thinking about. I guess one comment question. I guess this means we should probably stop doing studies trying to correlate VExUS or markers of venous congestion with CVP. I think that's kind of dead. Yes, there's a correlation, but clearly there is additional value to measuring congestion at an organ level because we're not just trying to assess a pressure, we're trying to assess flow. And I think that that's kind of one of the take homes. So if you're out there wanting to do a VExUS study, please don't correlate right atrial pressure with venous congestion. Instead, just focus on venous congestion associated with other outcomes or other markers. So that'd be my first thing. And the second thing is, how easy is a FibroScan to do? And do you think that we could theoretically use this as a marker at the bedside to monitor congestive, just congestion in general? So say, for example, a patient in the ICU, they come in with septic shock, you get like a baseline liver stiffness, and then if you notice that liver stiffness is going up, maybe you think maybe there's a worsening congestion. And then when you're trying to decongest them, you're looking for the liver stiffness to improve. Is that something you guys have thought about? And what do you think about that?
Yeah, we do not know. I mean, we have some experience because some of the patients that were included in this case series then later came back, and we happen to have fiber scans in some of them, and there's some dynamic changes. I'm not very sure the time frame it takes for when you decongest somebody for the fiber scan to normalize, or is it even possible to normalize it in all of them? Because some of them I have now irreversible fibrosis from long-standing congestion, and that might not be reversible. So we're in the process right now of studying the changes in FibroScan that happen in very congested patients. That's measured with venous Doppler, and then decongesting to our normal venous Doppler, and then repeat the FibroScan and repeat the liver function test to see if what's the time frame for improvement in organ injury. Actually, for this protocol, we are for those that do not achieve a normalization in FibroScan, even when congestion disappears, we're having liver biopsies done to see if there's a permanent fibrosis. And then that might be the problem because, of course,
Mm,
FibroScan will also detect liver cirrhosis, and that's
of
not
course.
treatable with diuretics.
Yeah, no, totally makes sense. Cool. I guess just thinking about the last couple minutes here, any other final closing thoughts here? That was such. Thank you for sharing that. Both of those studies are fascinating and cutting edge. Any other final thoughts here, and then I'll maybe make a few kind of closing remarks.
Yeah, well, once we are already here talking about cirrhosis, I will try to warn the audience that
Mm,
the venous Doppler is very different. The venous Doppler examination is very different in patients with primary liver disease, and that's your
mm,
hepatitis C, your alcoholic cirrhosis, or your metabolic syndrome induced cirrhosis, or NASH, or the new name, which I always forget about it. But this patients with primary liver disease have a very different waveform abnormalities, even when they get severely congested. So, in what scenario do we see this? Well, this is very frequent. Patients with cirrhosis are very likely to develop this syndrome, which is called high output heart failure. That's really just a combination of diastolic dysfunction, which is very prevalent in cirrhosis, and volume overload, which is very prevalent in cirrhosis. So you'll see very severe, sometimes extremely severe renal congestion and pulmonary congestion. And, if you don't actually need ultrasound, you'll see the JVP all the way to the head. And if you actually
mm,
do venous Doppler in the liver, you'll see a normal portal vein. In some of them,
mm,
you'll see a completely flat hepatic vein that doesn't really have waveforms. And I would really be trying to deliver this message. If your patient has primary liver cirrhosis and you look at the liver and it's small, scarred, nodular, it has ascites, the patient has signs of increased portal hypertension, such as esophageal varices or splenomegaly, then your portal vein is not going to be reliable. Your portal vein is
mm,
likely to be flat all the time, even in the face of severe congestion. Now, the other condition that you can see this is in patients that have primary liver disease, and then eventually over time they develop this portal pulmonary hypertension, which is also associated with severe congestion. And you again see a very normal non-pulsatile portal vein. Now, the other thing can also happen. A patient with cirrhosis and no heart failure, there can be some arteriovenous communications between the hepatic artery and the portal vein. And so the portal vein would kind of arterialize. And that means he'll
mm,
start pulsating. And that does
mm.
not by any means suggest heart failure or venous congestion. This is really a mechanical anatomical shunt that's happening in these patients. So I would just say if you're seeing a patient with primary liver disease, don't think portal vein Doppler can be useful for monitoring congestion. But if the kidneys are normal, then the same should apply as any other patient. The transmission of pressure from the right atrium should go to the small vessels of the kidneys when it's severe. And then again, we have a lot of experience. We actually have a prospective trial studying congestion in cirrhosis, and we've seen that the renal venous Doppler is pretty helpful to distinguish between those that actually need volume removal and maybe need some type of albumin resuscitation.